Just would like to introduce myself. I have been in the Southeast Valley in practice for over 16 years. Um, my education occurred in Tucson at the University of Arizona through medical school, residency, and a fellowship in sports medicine. I've had the opportunity over the years to work with several high schools and a couple of junior colleges. Early on in my career, a little work with at the professional level, and I've enjoyed working in sports medicine, and I am grateful for the opportunity to present this presentation. The presentation will cover some of the basics of ACL injuries, and then I would also like to talk about some of the newer things over the last few years that have come into play. Anterior longitudinal or anterior lateral ligament reconstructions, all inside techniques, and some of the research that's looked at graft selection. So let's go ahead and get started. Next slide. Just as a disclosure statement, I have no financial or relationships with companies as we talk about this presentation. Next slide. ACL injuries account for approximately half of all injuries reported each year. Over 400,000 ACL reconstructions occur yearly, and this just demonstrates how common this injury is and how prevalent it is. One thing that has been noticed over the years is that female athletes tend to have more ACL injuries than male athletes in a 4.5 to 1 ratio. And they also tend to injure themselves earlier in life at younger ages. Next slide. Let's talk a little bit about the female athlete and why they have an increased prevalence of ACL injuries. A lot of it has to do with a knee valgus moment and a hip adduction moment as they land. And you can see in the picture on the right the difference between a female athlete that has been trained and one that has not been trained. This landing moment is one of the reasons why they injure their ACL more prevalently than a male athlete. Towards the end of the presentation, we'll be able to see a comparison between male and female athletes as they do some jump and landing presentation. The other thing that may contribute to increased injuries in females are listed here. They have a smaller notch that can lead to impingement, to smaller ACL. They tend to be quadriceps dominant with hamstrings weaker than their quadriceps. Next slide. The pathophysiology of ACL reconstruction oftentimes is a non-contact pivot injury. The tibia translates anteriorly while the knee is in slight flexion and valgus, and non-contact injuries occur this way. Also can occur with a traumatic injury, a blow to the lateral knee. We see this common in female soccer players, male basketball players, and many of the other sports. Next slide. There are oftentimes associated injuries with the ACL injury. In the acute setting, the meniscus tears tend to be a little more common with the lateral meniscus, and in the chronic ACL deficient setting, the medial meniscus tends to be affected more often. Other injuries that may occur with the ACL injury, we can't forget about the posterior cruciate ligament, the lateral collateral ligament, and posterior lateral corner, and as well as MCL injuries. In the chronic ACL deficient knee, chondral injuries are common, and complex tears of the medial meniscus become a problem. Next slide. Prognosis. With ACL deficiency, if the ACL instability is not corrected and there is an ongoing instability problem, it accelerates the progression to osteoarthritis. With ACL reconstruction, we can restore the knee kinematics and have a high level of return to sport. And the evidence shows that it can slow down the progression to osteoarthritis. Next slide. Just a brief review of anatomy on the ACL. The ACL is composed generally of type 1 collagen and some type 3 collagen. It is the primary stabilizer to anterior tibial translation and is a secondary stabilizer to tibial rotation and varus valgus moments. There are two bundles of the ACL, and these bundles are named according to their attachment to the tibia. The anterior medial bundle is the more isometric bundle. It's tight throughout knee range of motion, especially in flexion, and it is the primary restraint to anterior translation. The posterior bundle is oriented a little bit more horizontal, and it is the primary restraint to rotational forces. Next slide. The presentation, athlete or patient tends to present having felt a pop, deep knee pain. Swelling occurs in 70% of ACL injuries due to hemarthrosis. They tend to complain of generalized knee pain and a feeling of instability. And this instability oftentimes will not allow them to return to play or continue in their activities. Next slide. On physical exam at the time of presentation, there's an effusion. Oftentimes a quadriceps avoidance gait is noted. Lack of full extension may be present with a meniscal injury, bucket handle tear, or with developing arthrofibrosis. Again, we need to make sure we evaluate for concomitant injuries, including perineal nerve injuries and the high energy injuries. Next slide. Examination. The Lachman is the most sensitive test, and there's a grading system. On the right, we're going to see a demonstration of the Lachman standard exam on the top slide. And on the bottom slide, this is one of the tests that I like to use as a drop leg Lachman. It forces relaxation of the hamstrings and is very useful in the larger patients, and it helps with this diagnosis. Grading system on Lachman, grade 1, 2, and 3 are noted. If we add A for a firm endpoint and B for no endpoint, this is very helpful in grading these injuries. Have to be careful on the exam to make sure that we're not missing a PCL injury. It can give a false Lachman. Next slide. The pivot shift is an excellent exam, but is often required to have the patient very relaxed. The knee is in full extension, and the tibia is subluxed anteriorly. And as you come into flexion, the IT band pulls on the tibia and reduces it. Another test is, and you could look this one up, it's called the Loci test, which is a gentle Lachman that also helps in this exam. Next slide. With the workup on knee injuries, we always have to get X-rays, AP lateral and patellofemoral views. Some of these injuries will include patellofemoral pathology and fractures. The Sagan fracture noted on the image on the right is pathognomonic for an ACL injury. It represents an avulsion of the anterior lateral ligament. And when this is present, ACL injuries are present in 75 to 100% of the time. Next slide. MRI allows us to confirm our clinical diagnosis and findings on the MRI. Discontinuity of the fibers, abnormal orientation of the ACL in a more horizontal position, or non-visualization helps confirm the diagnosis. The pivot shift contusions of the lateral compartment are a strong indicator that an ACL injury has occurred. Also allows us to see tibial spine avulsion fractures in the younger patients. It's very highly sensitive and specific. CT scan has a limited place for ACL Diagnosis and treatment can be helpful in the revision setting if we're concerned about tunnel widening or osteolysis or bone loss. Next slide. Treatment options for ACL injured patients. It needs to be individualized to the patient, and the important points are what is their activity level, what is the age, what are the demands, and concomitant injuries play a big role in how we treat these. If we decide to pursue non-operative treatment, it requires lifestyle modifications in many cases, and physical therapy is the mainstay. It may be relevant for patients with low demand and low laxity situations, or recreational athletes that don't participate in cutting and pivoting activities. I think the physical exam is important in making this decision. If there's a lower level of laxity, then these patients may do well non-operatively. Our concern is with outcomes with non-operative treatment, acceleration to develop osteoarthritis, and increased pathology with meniscus injuries and articular cartilage injuries. We have noted that functional bracing does not give additional stability. Next slide. ACL reconstruction, the purpose and indications are there. We want to make sure that we restore full range of motion before considering surgery, and this will decrease the significance of arthrofibrosis postoperatively. Exception to that would be a locked knee due to bucket handle tear or concomitant injuries that may lead us to intervene at an early stage. Young patients that are active need ACL reconstruction, so we'll eliminate concomitant injuries of the articular cartilage and meniscus. Children should be considered for ACL reconstruction when the stability is an issue. It's really not realistic to be able to limit their activities. Older patients that are active with high demands should be considered for ACL reconstruction. Age is not a contraindication in the high demand patient. Partial tears of the ACL with clinical and functional instability should be reconstructed as well. And in the setting of failure of prior ACL reconstruction, this should also be considered. Repair of the ACL historically has been abandoned due to high failure rates, but there is some interest in this technique, especially in the pediatric patient. And revision ACL reconstruction is indicated with a failed primary reconstruction. Next slide. The goal of ACL reconstruction is to restore anatomic stability and the rotatory stability. It's important as we do ACL reconstruction that we clear out the remnant fibers so that we can actually visualize the anatomic attachments at the tibia and on the femur. There are no reported differences in double bundle and single bundle reconstructions. The double bundle may give a better knee kinematics and less laxity, but with reported outcomes, there's no difference. And thus, I think the single bundle technique is the most common due to the easier technical aspects, but both of these are proven excellent ways to reconstruct the ACL. Next slide. Let's talk a little bit about femoral and tibial tunnel placement. One thing that we need to consider is historically the ACL reconstruction has been done through a transtibial approach, and comparisons of the transtibial approach and independent portals, there is no clinical outcome differences with these patients. We just need to consider placement of the femoral tunnel with these techniques. It needs to be down lower on the lateral wall at the 10 o'clock or 2 o'clock position rather than a horizontal position. And this gives a better stability to rotatory forces, as the the graft is more horizontal, it will give a better stability to the rotational forces. Next slide. Tibial tunnel placement. We want to try to get it anatomic, and the ACL footprint on the tibia sits approximately 10 to 11 millimeters anterior to the PCL. Other landmarks may include the median eminence and the intermeniscal ligament. I've found that the PCL and the lateral meniscus are my best landmarks. I like to place my guide tip at the edge of the lateral meniscus, and this puts us about 10 millimeters in front of the PCL. If you place the tunnel too far anteriorly, we'll deal with impingement in the notch. If it's placed too far posteriorly, it can impinge with the posterior cruciate ligament. Starting points on the tibia are typically midway between the tibial tubercle and the medial margin of the tibia. In a transtibial approach, that starting point can be moved more medially, and the trajectory can be a little bit more horizontal, and that will give you a good tunnel on the femoral side. Next slide. One thing to consider about the grafts as we choose grafts, graft preconditioning can reduce stress relaxation up to 50%. So as the assistant is preparing the graft, we need to make sure they place the graft on tension throughout that preparation to help reduce this stress relaxation. There's still some controversy present in the position of the knee when we tighten the graft or when we fix the graft. In my fellowship, the fellowship chairman fixed his ACLs in 20 degrees of flexion, and the fellowship director in 0 degrees of flexion. There is a current study in progress comparing 20 degrees and 0 degrees of flexion with patella tendon grafts, and expect that the results there will be forthcoming soon. I like to place my patient's knee in full extension as I tension the graft. Fixation of the graft will be dictated by graft selection. Patella tendon, bone grafts are fixed with interference screws with aperture fixation, and other fixation techniques such as cortical buttons, screws, washers, and staples are suspensory techniques. All of these have proven to be very effective and are good ways of fixing the graft. Next slide. A more recent technique of ACL reconstruction is the all-inside technique. Outcomes when comparing standard ACL reconstruction to all-inside techniques that show similar overall subjective and objective results. It's a little more technically challenging, and some of the advantages of the all-inside technique are smaller skin incisions, and this may be associated with decreased postoperative pain. Graft choices for the all-inside technique, you can actually use a single hamstring autograft, either semitendinosus or gracilis. And the reason you can use a single graft is that the length of the graft is shorter, and you can double, triple, or even quadruple a single donor graft. Allograft is another option, and it shows similar outcomes compared to all other grafts. Allografts do show a higher graft failure rate in the postoperative period, and this is something to consider as you discuss graft selection with your patients. There's a higher cost with the all-inside technique that has to do with the disposable instruments. Next slide. Revision ACL reconstruction. When the patient presents to our office with a re-injury after ACL reconstruction, we need to try to figure out why this occurred. Oftentimes it is a compliance issue. They've returned to sport before they should have. Perhaps they were not completely rehabbed. Malalignment is something that needs to be looked at, especially in this situation. And if alignment issues are not corrected, it can lead to failure of your revision. Graft choice may come into play here as well. With revision ACL reconstruction, we have to look at the concomitant pathology. Sometimes a PCL injury or a posterior lateral coronary injury was missed, and this can lead to failure of the original ACL reconstruction. Next slide. With ACL revision, we need to use grafts that are high strength. Allografts can come into play with this. They're very good grafts in the revision setting, especially in a multi-ligament injury. Studies recently have shown that an autograft in the revision setting has lower re-rupture and failure rates compared to allografts, and this is about a 4-time difference. So even if we've used an autograft in our original ACL reconstruction, there are options to go back to the patient and use a different tendon, whether it's a contralateral hamstring, or whether it's a hamstring graft with BTB failure, or vice versa. The quadriceps graft is also an excellent graft to be considered in the revision setting. Fixation can be dual or with backup fixation to ensure that this isn't a source of failure. Bone grafting will come into play if there's tunnel dilatation or if the original tunnels interfere with an anatomic tunnel placement. The addition of the anterior lateral ligament reconstruction has shown improved outcomes in the revision and primary settings. It's contraindicated to reharvest the patella tendon. I think that speaks for itself. Thing to consider with postoperative care in the rehab setting: go slow, be conservative. I like to add 3 months to the recovery when I talk to my patients about their return to sports. It can take 9 to 12 months for some of these patients to get back to normal. Next slide. Let's talk a little bit about the anterior lateral ligament reconstruction. This has gained popularity in the last 4 or 5 years. It is controversial, and controversial to me just indicates that there's not a consensus whether this is of benefit or not. The original studies looking at comparison of ACL reconstruction with an addition of the ALL versus standard techniques, there was a subjective and objective knee score improvement in these patients, but follow-up studies were required. Some of those follow-up studies have occurred in the high-risk population, teenagers and 20-year-olds. The rate of graft failure is 2 to 3 times less with the addition of the anterolateral ligament reconstruction, and the odds of them returning to sport in the revision setting with the addition of this procedure are greater when compared to the hamstring alone reconstructions. There is no significant difference in graft fixation angles. Oftentimes a 30-degree angle for tensioning of this graft is cited in the techniques, but studies have shown that the fixation angles don't make a difference. Cadaveric studies have shown over-constraint in the knee following ALL addition, and we're not sure how this affects the patient clinically. One significant advantage to adding the ALL to the ACL reconstruction is it does tend to protect the meniscus repairs. Meniscus repair survival with the addition of the ALL reconstruction are up to 91% compared to 83% in the ACL reconstruction alone. Next slide. Graft selection. Advantages of selecting an autograft. It is the patient's own tissue. This is the most common source for ACL reconstruction. Using your own tissues will result in faster incorporation. There won't be an immune reaction or disease translation with these grafts. The pros and cons of allograft: it is very useful in the revision setting and in the multi-ligament injury patient. There's no harvest site morbidity. Does take longer for these grafts to incorporate, so you have to slow down the return to activity a little bit. It is more expensive. An allograft can cost anywhere from $1,200 to $2,500, depending on what we're dealing with. There's a risk of disease transmission, but this is very remote. It's noted to be 1 in 1.5 million for HIV and a little bit greater for hepatitis. There has been shown a higher incidence of re-rupture rate using allografts in the young teenage patient, and in some cases up to 4 times higher in these using the allografts in this patient population. I try to avoid the use of an allograft in the teenager and 20-year-old population. Next slide. Pros and cons of the patella tendon graft: it has the longest history of use. It is considered the gold standard in the NFL and in high level athletes. It is a stiffer graft, and it provides a bone-to-bone healing at both the tibial and femoral fixations. It is a rigid fixation, so you will avoid the windshield wiper effect or the bungee effect that you may see with soft tissue grafts. Anterior knee pain has been reported in 10 to 30% of patients undergoing patella tendon autograft reconstruction. It has a high load to failure rate. There are some complications that can occur with patella tendon grafts, patella fracture or tendon ruptures. This typically occurs in the younger patient with the smaller grafts. Quadruple hamstring is another graft that is very popular and does a very nice job. There's smaller incisions, less perioperative pain, and no anterior knee pain issues. The flexion strength at 3 years following surgery is less when compared to patella tendon grafts. And some of the complications, you can have paresthesias associated with the tibial incision and the residual hamstring weakness. Next paragraph, next slide. Outcomes comparing patella tendon and hamstrings. This has been studied for decades. There are equal clinical outcomes comparing these two grafts. So both of these grafts are excellent choices with excellent outcomes with return to sport and activity. Next slide. Next slide. The quadriceps tendon autograft is another option for ACL reconstruction. There's some advantages. It is a small incision above the patella. There's no pressure during kneeling. Doesn't involve a physis. Good maximum load to failure strength, and similar outcomes to all other autografts. The nice thing about this graft too is if you need a bone block, you can take a bone block along with the soft tissue, or it can be a completely soft tissue graft. And this may be a good option for an autograft in the revision setting. Next slide. There are concomitant injuries that can occur with the ACL injuries, and we need to make sure that we don't overlook these. And then the question is, when can we perform surgery in the setting of these concomitant injuries? With the MCL, if it's a low-grade injury and it's non-operative, we can allow time for this to heal, make sure we regain range of motion before we proceed to ACL reconstruction. In high-grade injuries, if it needs to be reconstructed or repaired, this can be done at the same time as the ACL reconstruction. Failure to address these medial injuries can jeopardize the graft and result in higher re-rupture rates. Meniscus tears should be performed, the treatment of these tears should be performed at the time of ACL reconstruction, whether it's a meniscectomy or a repair. And we have greater healing responses with the meniscal repairs in the setting of ACL reconstruction. Next slide. Condyle injuries. These, if they're recognized preoperatively, Some planning can take place. If they're small, full thickness defects in OATS, procedure can be done at the same time as an ACL reconstruction. If it's a larger defect, then we need to consider articular cartilage biopsy and a staged procedure with these cases. The presence of the chondral injury does lower the long-term outcomes, development of arthritis, and poor long-term outcomes. PCL injuries and posterolateral corner injuries. These can be done concurrently with the ACL reconstruction, and that's my preference, and they can be done in a staged manner. And we need to make sure we don't miss these injuries because it has a significant effect on long-term outcomes and re-rupture rates of the ACL. Next slide. Malalignment, we need to consider this, especially in the revision setting. What are the causes for the failure of our primary ACL reconstruction? And if there is a significant alignment issue, it needs to be addressed with high tibial osteotomy. If these are not addressed, then we may go on to continued failure of our reconstructions. Next slide. Let's talk a little bit about the postoperative recovery immediately following surgery. Aggressive cryotherapy and immediate weight bearing is encouraged. The weight bearing reduces the patellofemoral pain, and early passive extension needs to be carried out. This is the most difficult motion to get back after ACL surgery is extension, and that needs to be addressed immediately. In the early post-op period, eccentric loading exercises will increase quadriceps volume and strength, and this needs to be started early in the process. Isometric quad and hamstring contractions are important, active knee range of motion, and closed chain exercises. Things to avoid in the post-op recovery phase: open chain quadriceps strengthening and isokinetic strengthening in the 15 to 30 degree range. This exercise mimics the pivot shift. Next slide. Return to play. There are no widely accepted criteria supporting the clearance or timing of return to play. It is an individual, it's on an individual basis. Each patient and athlete will be different in their recovery. A previously held consensus is a 9-month time to return to play. Accelerated protocols have been effective, and so some patients will be ready to return at an earlier time. Functional testing can be very helpful in the return to play. Single and double leg hop and jump exercises can help us determine if they're ready to return. I think quadriceps girth is another thing that's important. If we can get their quadriceps girth equal to the opposite side, then that's another indicator. Return to play prior to clearance results in higher re-rupture rates, and we need to remember that the decision to return to play is between the surgeon and the athlete, not between the athlete and the trainer, and not between the athlete and coach. This is something that the surgeon and patient need to decide upon. We can't forget that there are psychological factors that may play into the ability for an athlete to return to sport. Let's look at this last slide, looking at the comparison of the male and female athlete. And the top row in these pictures is a male athlete jumping and landing compared to the bottom row, the female athlete. And the female athlete, you can see as they land, there's a valgus moment at the knee, an adduction moment at the hip, and there's less flexion. And this situation is what leads to a higher incidence of ACL failures in the female athlete. Female athletes need to be trained in jumping, and they need to concentrate on increasing hamstring strength, which will reduce that quadriceps dominant ratio. And studies have shown that training can make a difference in these female athletes. Skiers need to be trained how to fall. ACL bracing does not prevent instability, but it is effective in the ACL deficient skier. That does it for the for my presentation. I thank you for the opportunity to present this. And special thanks to my physician assistant, Clay Shorter, in helping with the graphics and the presentation. Just a reminder, as you read this slide, it is a CME activity, and email to Stacy King will help you obtain your CME credit.